Good morning, everybody. Good morning and welcome to our event. Firstly, I'm Doireann O'Mahony for anyone who doesn't recognise me and know me. And I want to say a very big thank you to Croí, the Heart Attack and Stroke Foundation, for facilitating this very important discussion this morning, all about sudden cardiac arrest. And we have an expert panel of speakers from various disciplines who've kindly given up their time to be here with us this morning and share their knowledge with us. And I wish to thank each of those as well. To the participants who have given so generously of their time and their donations to be here, thank you very much. It is hugely appreciated. Sudden cardiac death accounts for thousands of deaths a year in Ireland. Some say that 2 a day occur. So for most of us here, sadly, we will know somebody who has died from sudden cardiac arrest or will do so. And today is about raising awareness and understanding about what we can do to prevent those deaths. A horrifying and shocking scene unfolded 4 weeks ago tomorrow when Christian Eriksen, the Danish star, collapsed. And that was broadcast live across the world, and the scenes shocked people who saw the events unfold in real time. Fortunately, he got expert help, but you know, a sudden cardiac arrest can happen to anyone at any time, during exercise, during rest, or even when a person is asleep. Every death leaves behind a massive void within a family, a circle of friends, and a community. And survival outside of the hospital setting really depends on people like you and I, bystanders calling the emergency services and prompt bystander emergency response. So our message today is learn CPR, teach CPR, talk about CPR, and know where your nearest defibrillator is. We can all play a part in saving lives. And for those who have lost a person to a sudden cardiac death, they will say that every life lost, no matter the person's age, is one too many. So with that, I would like to again thank you all, and I will hand over to the Honourable Mr. Justice Anthony Barr, Judge of the High Court, who has very kindly agreed to be here with us this morning and share a few thoughts. Thank you.
Good morning, ladies and gentlemen. My name is Anthony Barr. I hope you can see me and hear me satisfactorily. And I'm delighted to have been asked by Ms. O'Mahony to open this conference for you today. And happily for you, I'll be able to tell you that I'm in fact the only lawyer that you will hear from, and I'm going to be extraordinarily brief. So I'm sure that is good news for you. It may have been a little bit worrying for some of the speakers that are going to talk this morning when they heard from Ms. O'Mahony, because she, of course, is an author of a number of books on aspects of clinical negligence. And then when they saw that I was opening the conference, because I have, while not in that list at the moment, but I have done for a number of years in the personal injury list, done a number of cases involving clinical negligence. So I hope that doesn't scare some of the medical speakers that are coming later this morning, because normally the last thing they would want to see is someone like me, because it probably means they're at the wrong end of a clinical negligence claim. But I can assure them that there's nothing like that on the cards today. As Doireann pointed out, the whole topic of sudden cardiac arrest was really thrust onto the world stage with the event involving Christian Eriksen. But as she has said, it is so important to realize that while that event was seen by millions and therefore is in the consciousness of the television watching public throughout Europe, it does happen every single day, and it can involve people, young, old, and more importantly, can involve bystanders who are just passing by. And I think it was something in the small bio that I got in relation to Cathal Joyce, a footballer who had, Gaelic footballer who had a cardiac arrest or cardiac condition. And he will be talking later, but he said something I think that really resonated with me. He said, learning CPR after you have been engaged with somebody who has had a heart attack is a bit like buying a security alarm for your house after you've been burgled. In other words, it's a bit late. And certainly, if I have taken anything from listening to or being aware of what the speakers are going to talk about, it is that I will make a big effort to try and learn CPR. In fact, in fairness to the court service, they did put a course in place for the judges, and they do have defibrillators here around the courts because it's obviously a public building. It's being used by people of all ages and sizes and health conditions. And but unfortunately, I happen to have been away on circuit at that time. But I will make a pointed effort to try and get onto another course to learn CPR. And I would urge all of you to try and do that. Make that a mid-year resolution and not a New Year resolution, and try and learn CPR wherever you can, from the first aid or John's ambulance or in your local community hall. And then also try and be aware of it where the defibrillators are in the public places that you frequent, such as clubs or, again, community halls or places of religious worship or whatever it may be. The lineup of speakers is extraordinarily interesting for you today. I'm not going to say a great deal about each of the speakers because I think it's kind of better that Ms. O'Mahony introduces each one of them individually rather than me introducing them globally. But just very briefly, you'll hear from Professor Sharma, who is Professor of Sports Cardiology and Inherited Cardiac Disease in St. George's University of London, who has a huge experience, particularly dealing with elite athletes in the UK across a number of disciplines. And it'll be very interesting to hear what he has to say, both in relation to elite athletes participating in different types of sports, such as athletes participating, obviously England participating very well in the Euro 2020 championships, but also the Lions going on tour. And then you've all the athletes going out to the Olympics in Tokyo later in the summer. You'll also hear from Dr. Chris Danbury, consultant in intensive care from University Hospital in Southampton, and from Dr. Conor Deasy, professor in emergency medicine in UCC and a consultant in accident and emergency medicine in Cork University Hospital. And then lastly, on the medical side, but by no means least, you will hear from Dr. Nick Flynn, who is an extremely experienced GP, part of the largest GP practice in Cork. And he will be able to tell you, excuse me, the importance of either knowing about CPR or trying to keep good cardiac health for ordinary people that come into his clinic on a day-to-day basis. Finally, then you'll hear from briefly from two speakers, Cathal Joyce, the Gaelic footballer that I referred to, who had the sudden event in the course of a competitive club match some years ago, and who since then has spent a lot of time going around the country teaching people. But it was he who made the comment about learning CPR after you've had to perhaps try to come to the aid of somebody who appears to be having a sudden cardiac event, and that being a little bit late. And finally, then you'll hear from Neil Johnson, the CEO of Croí, and it's a wonderful charity, and I'm delighted to play some very small part in promoting it or helping it along. So finally, I would just say three thank yous. Firstly, to the speakers for their time and knowledge, and I think you will gain a lot from their presentations. Thank you to Doireann O'Mahony BL for putting all of this together and cajoling us all and getting us all in the one room, if you like, even remotely, at the same time and at the same place and with the same aim in mind. And that's a that's a difficult enough job, and she's done it very well. And finally, a thank you to each of you watching, and particularly those who have made a donation to the charity. I hope you gain as much from today's conference as the charity will from your donation. Thank you very much, and I hope you enjoy the morning. And I apologize that I won't be able to stay for the entirety of the conference, but I'm afraid other work commitments today prevent that happening. Thank you very much. I'll hand back to Doireann now.
Thank you very much, Judge Barr. We really appreciate you being here. I know you have a very busy schedule, and you have a list starting soon. So thank you so much for everything that you've said. Everything that you've said really rings true and is resonating so much with me, as I'm sure with all of the other participants here. So a very sincere and wholehearted thank you to you, Judge Barr. Thank you. And from there, I suppose we will move on, and proceedings will start with Cathal Joyce. So Judge Barr has mentioned that Cathal is here this morning. There you are, Cathal. So we're delighted to have you, Cathal, and I say most of the participants will know who you are and know a bit of your story, but while you're here, it's great to hear firsthand from the horse's mouth about your experience back in September 2015, when you were, I think, just 25 years of age, warming up for a game when you had a sudden cardiac arrest. So can you tell us, what do you remember about that?
I can remember the build up to it now. You know, I'll give the brief story on it. Like, we did a warm up prior to the game on a different pitch. We landed at Cusick Park in Mullingar, had our team talk, back out on the pitch, started a light warm up again, kicking a ball. And I just started feeling dizzy and my coordination was going. And I just said to one of the lads, would you bring me over to the dugout? And he had to link me across into the dugout. And with that, my brother came over. He was physio on the day, asked me what was wrong. I just told him I wasn't feeling good. I felt weak. With that, my vision went and I collapsed on the ground.
Wow. Lucky that your brother was there. Very lucky. So afterwards, Cathal, I think you were taken to a local hospital there.
Yeah, so when I collapsed there, I got 3 rounds of CPR and 1 shock off the defibrillator.
Yeah, and that saved your life.
That saved my life, yeah.
Yeah, very fortunate that there was, as you said, people, bystanders like your brother, and of course the defibrillator there, yeah, which was crucial. But you were taken then to the hospital, and I think you were diagnosed sometime later with hypertrophic cardiomyopathy.
Yeah.
Can you tell us a little bit about that and what it was like for you finding out about that and being told?
So, yeah, basically being told that, they said sports would be finished. You might be able to do a bit of walking, a bit of golf, and you know, you won't be playing to a level again of football or sports. But at 25 years of age, you don't want to be hearing these things. And all I've done all my life is play sport, and you know, from cycling to tennis to golf to, you know, horse riding, you know, I've done everything. It's not very nice to hear that. Like, it was a busy week between getting tests done and stuff, and then being told I'd be getting an ICD put in as well.
Yeah, so you had an ICD inserted somewhere under the collarbone.
Yeah.
Can you tell people about that?
Yeah, so basically, yeah, so like at the time I didn't really know much about it, you know. I didn't really think. All I wanted to do was get home. Yeah, so it's inserted under my left collarbone. So the ICD, it's a, say, people call it a pacemaker as well. But look, if I need a shock or that, it'll do it for me, you know. It's my own little defib carrying around inside me.
Yeah.
So I went back. They told me I wouldn't play sports again. I played my first match 6 months later.
Wow.
I got a shield med for the ICD, so it can take impact and stuff. So I've no issue since with that, you know.
Amazing. So you are obviously somebody who had devoted your whole life to the game and to sports, and you're still an advocate for fitness, aren't you? And you're
Yeah.
so much active in the football world.
Yeah, I went back and done my personal training and stuff like this. Just most recently there during COVID, I said I'd make use of it. I went to UCD. I did the cardiac rehabilitation course there. So just passed all that there now most recently. So just because like I had no rehabilitation myself, like most things I done to get back, I done it all myself, like, you know, which is scary. It's just scary at 25 years of age, you know.
You were very young. And how did your family and your friends deal with it or cope with it? Was it a shock to them as well?
It was more of a shock to me, I think, literally. Yeah, I suppose, look, to be worried and stuff, but look, I'm positive in myself, you know, I'm a positive person anyway, but always a good outlook on things, you know. It could have been a lot worse.
Absolutely, yeah. So you have a great attitude, Cathal, and you're absolutely passionate and outspoken about the importance of training in CPR and the availability of defibrillators. And I think you even set up your own group called Heart Talk, and you've traveled around the country and even abroad, I think, speaking on the subject. So do you want to say a few words about that?
Yeah, but I just had Heart Talk set up. You know, I was getting an awful lot of messages and on my own Facebook page, so I kind of just took it away from that. So I was just putting up stories on it and just CPR classes and where to go. Like I was in Vienna. I was brought to Vienna for a few days to do a talk.
Amazing, yeah. Just
on my story and my comeback and that kind of stuff. I've been in schools. I done Rinka classes. I think I've 200-300 kids training CPR from the age of 3 up. Wow. You know, it doesn't matter about their strength at that age, but they just know the technique. And it was amazing then in the evening, like the parents would be sending you a picture of WhatsApp where the kids are actually showing them CPR, what they learned, and like they never forget it. Like, you know, I know they mightn't have the strength at that age, but it's like riding a bicycle. You'll never forget it, you know.
Yeah. So your bounce back and your comeback is just so amazing and so inspirational. Your story is incredible. You're a great example to so many people, Cathal. What is the one piece of advice or inspiration that you would have to give to somebody who may find themselves in the same position as you?
As me? Oh God, like that. It's always brighter on the other side, like, isn't it? Like, I know when I was going through this, I just was, throughout the whole lot of it, all I was being told is all the things I can't do. Went into the doctors and I just said, just tell me something I can do. Yeah. And I can work on that. Like, it was, I think the biggest shock for me was when I was leaving the hospital, to give me a booklet, how to live with an ICD. And on the front of the booklet, this might is 2 older people sitting in a park. You know, it's not a great thing for a 25-year-old active, still wants to be active. You know, all that's in this booklet is what you can't do. Like, I want to know what I can do. That was kind of annoying to me. But like anybody there, like doctors, find a doctor you're comfortable with and ask questions. Write them down, be prepared, and just take every day as you can, you know.
Brilliant. It's such a powerful and impactful message. And I know, Cathal, that you're busy. Cathal is at work today and he's very kindly
jumped on for a few minutes.
Take time out to talk to us. And so, you know, you're thriving, Cathal, really. You're working away in social care. You are still playing several nights. And you obviously are an advocate for CPR training and defibrillators.
Yeah.
So, you know, thank you so much for being here from all of us to share your story, which is truly amazing. And hopefully it's one that will, you know, resonate with everybody here and that they will bring out into the wider community, to the people who aren't here watching you. And I'm sure we'd love to have you back again in the future. But, you know, just hearing about your recovery and your comeback and where you are today and your message is really powerful and it's really fantastic. So from me and from everyone, Cathal, I want to say a big thanks. And just before we let you go, what would be your one sort of important message, or what would be the one takeaway that you would want everybody watching here this morning to go away with?
The countries after being flooded with defibrillators, check them.
Check them, yeah.
It's no good having them there and just buying it, looking fancy, getting a picture taken with this defibrillator. It's the maintenance after. Like the defibrillator that was used on me, there was only enough battery in it for one shock.
Wow. So
that's on a county pitch, maintenance, yeah. And you need CPR with a defibrillator to give that person the best fighting chance. It's no good just having a defibrillator. You need CPR and a defibrillator. Check them out. There's loads of them around towns, GA clubs. Assign someone to it and make sure they're working. Pads, battery. It's very simple, 5 minutes to check it. And look, it's the difference between saving someone's life and giving them a better chance of survival, a better percentage.
Absolutely, yeah. Comments coming in here saying, well done, Cathal, thank you so much. So listen, Cathal, on that note, we will let you go. I know you're very busy. Thank you so much once again. It was fantastic having you, and we'll stay in touch.
Thanks very much.
All the best.
Bye.
Thank you, Cathal. So that was fantastic. And from here, we're going to be moving into the portion of the morning where we hear from the professional speakers. So I just want to point out as well to the participants that there is a chat box at the bottom of your screen. So if at any stage you wish to leave a comment, some feedback, or maybe if you have a question for the speaker, you can put it in there, and we will certainly be keeping an eye on that, and we can pass questions to the speakers as they arise. So I'm very pleased to introduce our first speaker this morning from the panel of medical speakers. He is Professor Sanjay Sharma. Professor Sharma has a passion for sports cardiology, which was sparked when he was awarded a fellowship from the British Heart Foundation to research athletes' hearts. And that was in '97. And in 2010, Professor Sharma was appointed Professor of Sports Cardiology and Inherited Cardiac Diseases at St. George's University Hospital in London. He's also the medical director of the London Marathon. He's the cardiologist for the British Rugby League and for the British Lawn Tennis Association. I could go on and on. He leads the cardiac risk in the young screening program, and he screens athletes from most GB national athletic squads. And some of you may recognize him from his appearances in recent weeks on television, because he also worked, of course, with Christian Eriksen up until 2019. So welcome, Professor Sharma.
Well, thank you very much indeed for having me, and it's a real pleasure to be able to speak today. Can you all see my slides? I'm going to be talking to you about prevention of sudden cardiac death in sport. My disclosures are that I have received fees for providing cardiac screening for athletes and managing athletes with cardiac diseases from several sporting organizations. And I will not be speaking about any one particular athlete when I give this talk. I'll be speaking about athletes in general. So let's go to the main talk. The benefits of exercise on the cardiovascular system are well established. It's well recognized that people who exercise regularly are less likely to have high blood pressure, diabetes, or have obesity. And by curbing all of these risk factors for cardiac disease, people who exercise regularly live between 3 and 7 years longer than people who are sedentary. In this respect, young athletes really are the epitome of the healthiest segment of our society. These young individuals push themselves to the limit for club and country, and they astound us with their extraordinary physical abilities and their stamina. But every now and then, one such young individual dies suddenly during training or competition. Such deaths are highly publicized by the media and really do capture the hearts of the nations, because they are affecting individuals who are really healthy and they can be associated with loss of several decades of life. So today I'll be talking to you about the causes of sudden cardiac death and what we do in sport to try and prevent these catastrophes. So let's look at sudden death. Well, exercise can either precipitate myocardial infarction or sudden cardiac death in people who've got an underlying cardiac problem. So you've got to have an underlying problem for something to actually go wrong. Now, if you're more likely to die suddenly during exercise than at any other time, or more likely to have a heart attack during exercise than at any other time. So if we look here, this is a blood vessel with a slight narrowing in it. Now, during exercise, there are certain stresses such as metabolic factors, shearing forces, and high levels of adrenaline, which can cause this plaque to rupture and start to block. On occasion, there may be an oxygen demand and supply issue that may result in lack of oxygen to the heart. And all of these situations can put the heart into a very dangerous rhythm called ventricular fibrillation, which can only be treated by a shock. So this is the sort of thing that usually kills people who are 35 years old or more. When we look at young athletes, these are people under 35, deaths are due to a diverse spectrum of cardiac diseases that are either genetic or congenital, and they can often affect the heart muscle, the electricity, the valves, or the blood supply. In any case, a young individual with one of these conditions is 3 times more likely to die compared to a sedentary individual with the same condition, suggesting that exercise is a trigger in people with pathological substrates such as blocked arteries or heart muscle faults. So during exercise, of course, apart from having this condition, dehydration, surges in adrenaline, electrolyte imbalances can put someone into a dangerous rhythm. So we've got several preventive strategies, not just in elite sport, but in the general population to try and reduce the risk of such a catastrophic event. And one is athlete education. The second is to actually perform active screening to identify people who may have serious cardiac disease. And the third is the provision of an automated external defibrillator, which is truly a lifesaver. When it comes to athlete education, and this should apply to everyone that's actually listening, you need to be aware of symptoms that are actually suggestive of cardiac disease, such as chest tightness during exertion, breathlessness that is disproportionate to the amount of exercise being performed, exertional dizziness, so you're actually getting lightheaded when you're running rather than when you've stopped running, rapid beating of the heart, these are called palpitations at times that you don't expect it to, or a blackout. People should also be aware to be tested if they've got a family history of premature cardiac disease or sudden cardiac death. And by premature, I mean someone who is aged 50 or less, because many conditions that cause sudden death in sport are genetic. Older people should be aware of risk factors for coronary atherosclerosis. This is the process that causes narrowing and blockage of the blood vessels. So they need to be aware that they may need testing if they've got a long history of high blood pressure, diabetes, obesity, high cholesterol, or even a family history of premature cardiac disease. People should not exercise when they've got a temperature or a lower respiratory tract infection because they may be harboring something called myocarditis, which is inflammation of the heart muscle, usually caused by viruses that can cause trouble during exercise. And people should be aware of the dangers of performance-enhancing agents, which can actually precipitate dangerous rhythm disturbances. So this is athlete education. But in elite sport, of course, we go out actively to identify people who may have a cardiac condition, such as in Cathal's case. So cardiac screening in Europe involves a family history, taking a family history and a personal history and doing a 12-lead ECG. The 12-lead ECG is the simplest form of test that can be performed in cardiology. And the 12-lead ECG is very effective at identifying serious electrical faults that may cause cardiac disease. And I'm not going to talk about all of these, but these are all serious faults that can be picked up quite easily with a simple test such as an ECG. And many of these conditions can actually be treated effectively, and so that the athlete can go back and play sports such as WPW. We can actually cure WPW. In Italy, where they've got a screening program such as this in place for 30 years, they've seen a tremendous reduction in exercise-related sudden cardiac death. So here you've got two lines. The red line represents deaths in athletes, and the yellow line represents deaths in non-athletes. You will see that the deaths in non-athletes, these are people that aren't screened, has remained static, and it's been considerably lower than in the athletes. But if you look at deaths in athletes in 1979, that was about 4 per 100,000. And as soon as they implemented their screening program, these death rates have steadily gone down further and further and further and further, from 3.6 per 100,000 person years to 0.4 per 100,000 person years, suggesting that screening is effective and can reduce the risk of sudden cardiac death by about 90%. However, there are lots of concerns relating to screening. Firstly, that sudden cardiac death in sport is uncommon. It usually affects, according to the general data, about 1 in 50,000 athletes. There are risks about false positives because exercise itself can cause changes in the ECG that may be mistaken for a serious cardiac condition. There are concerns about false negatives. You saw the events on television about a young athlete who'd had several tests where nothing was found and he went on to have a cardiac arrest. There are also concerns about diseases that cannot be identified with screening. And of course, there is a cost issue that one needs to also consider. So let's talk about the low incidence of sudden cardiac death. And I'll tackle this one. We did a study on the FA screening program. The FA screening program has been in place since 1997, where every single scholar who's aged between 16 and 17 has to undergo a mandatory cardiac assessment before they can sign a professional contract. So we had data in over 11,000 such adolescent athletes, and they were followed up for around 10 years. That's 118,000 person years. During this time, there were 25 deaths, 8 from cardiac conditions. And based on this, we could work out an accurate estimate of the incidence of sudden cardiac death. And you will see that the incidence of sudden cardiac death is 1 in 15,000. That's 3 times more common than any other data has ever reported. And this is probably the best study that's ever been done in cardiac screening. I was slightly alarmed to see that sudden cardiac deaths is about 5 times more common in Black athletes than in white athletes. And this clearly requires further investigation as to why the Black population is more vulnerable to exercise-related sudden cardiac death. But of course, even if we weren't doing this, what should we be using as an argument to screen? Is it just the death rates, whether it's 1 in 15,000 or 1 in 50,000, or is it the number of people that you will pick up? Well, here you can see lots and lots of studies from different countries, but what I want you to focus on is the prevalence of conditions that can cause a sudden cardiac death here. And you will see that in the UK or in Ireland or anywhere else, 1 in 300 young people carry a condition that could potentially kill them. Now, you need to be aware that most young people do not have the fortune of having annual screenings, such as elite athletes. So these are people in the population that have conditions that could potentially kill them. What about the risk of false positives? It's true to say that the ECG in an athlete may simulate the ECG in someone with cardiac disease. And I'd like to reassure you all that we've done a lot of work on this, and we've created something called the International Recommendations for how we screen athletes. And this has reduced the positive number of ECGs in white athletes down to 2.5% from around 11%. Despite this improvement, the sensitivity for diagnosing serious disease has been maintained above 90%, and the specificity for diagnosing serious disease has increased to 97%. In fact, if an athlete has an abnormal ECG, the chances of us finding something serious in that athlete is almost 1 in 5. What about the concerns relating to false negatives? And this is where the defibrillator really does come in, because we will not identify everyone with cardiac disease. And I'd like to highlight this here. So there are many other conditions, and I know that most of the audience is not medically trained, but there are conditions that affect the blood supply of the heart, or conditions that can only be picked up during intensive exercise that will not be picked up during a routine screen. Some athletes have got incomplete expressions of disease that may not be identified early on in their lives. Then there are things that can happen on the pitch, such as electrolyte imbalance disturbances or inflammation of the heart muscle that the athlete may not know about, that can actually cause a sudden cardiac death. And this study here that I talked to you about earlier that we did in our Football Association players, during this 11 years that we followed them up, there were 8 deaths, as I said to you. Our screening program only picked up 2 of those 8 deaths. So we missed 75% of deaths. And you may say, well, that suggests that screening must be a complete waste of time because you missed 75% of people who were going to die. But I'd like you to look at it another way. The time between screening and sudden death here was 7 years. And you need to remember that these people were adolescents when they were tested. And what this study tells us is that a one-off screen at the age of 16 is not enough because diseases that are not there at the age of 16 may be rife and obvious by the age of 22. And it's for this reason that the Football Association has now increased their screening, not just from 16, but they screen every 2 years at 18, at 20, and above 21, they encourage the clubs to screen their players every 2 years or so. Now I'd like to address the issue of defibrillators. Here is a bar chart showing you deaths in the community. The red bars represent the young competitive athletes that I've been talking to you about for the last 15 minutes. And the blue bars represent deaths in recreational athletes. And you will see that the vast majority of deaths during sport don't occur in the creme de la creme athletes like Christian Eriksen. They occur in the community, and they usually affect men between the ages of 45 and 55 years old. Men are much more predisposed to exercise-related sudden cardiac death than women, with a ratio of 20:1. And the vast majority of these men that collapse, actually have coronary artery disease, which will not be picked up by a simple 12-lead ECG. So we need something more, such as CPR and defibrillators in the community. Here is data from 2 countries, and you can judge from yourself. The first country is the Netherlands, and the other country is France. And these are data on men that had had cardiac arrest. You will see in the Netherlands that the mean age of the male was about 59. And in France, it was 46. The French were younger when they arrested. Bystander witnessed arrest was high in both. So these arrests were actually witnessed in both countries. But just look at the success rate of survival. In the Netherlands, it was 45%. So 45% of all people that had a cardiac arrest survived. In France, it was only 15%. So what's the reason for that? Well, look at the difference in the CPR and the AED use. In the Netherlands, bystander CPR was initiated in 87% of cases versus only 31% in France. And the AED was used in 36% of cases in the Netherlands versus only 1% in France. And as a result of that, the initial shockable rhythm, the level of that was much, much higher in the Netherlands, 80% versus only 47% in France. But even then, they could have done a lot better. Look at the time to the first shock, almost 10 minutes in the Netherlands and 12.5 minutes, which is just too long, if you ask my personal opinion. If we actually look at sudden deaths in sport, where people are being monitored and watched, there is a massive, massive improvement. So if you go from down upwards, you will see that the initial survival rate was 23%. At the London Marathon, which I proudly look after, our success rate is 45%. But in schools where they've got defibrillators throughout and diligent coaches, the survival rate is 64%. And in certain small marathons, such as in the Japanese marathon, the survival can be as high as 93%. Indeed, ladies and gentlemen, I can tell you that early introduction of CPR increases the chance of you surviving 4-fold compared to no activation at all. What do you need for this? You need good personnel. You need people who know what they're doing. And it's for this reason that I believe that everybody should be taught CPR. It should be compulsory at school so that this is a lifesaver. Clearly, in sport or everywhere else, you need to know where the AED is kept. There's no point having an AED if no one knows where it's kept, or it's locked away somewhere, or if it's not being maintained, as Cathal pointed out, that the AED only had a battery life of 1 shock. So this needs to be monitored, maintained, and serviced. There should be an effective communication system between individuals as to who is going to make the call, where the defib is, who's going to make the run, who's going to be responsible for using the AED that day. And in sport, of course, there should be a practice and review of the emergency response plan at all times, so people are prepared as they were a couple of weeks ago. Now, to be successful, the mean time from collapse to CPR should be just 1.5 minutes. That you should not allow more than 1.5 minutes before you're on the chest making chest compressions. And the mean time from sudden cardiac arrest to first shock for a really good outcome should be less than 4 minutes. So it's quick action. And if you've got members of staff who know what they're doing, if there is the ability of a defibrillator, that's excellent. But even if you do not have a defib, you will be making an incredible contribution to the survival of a young individual if you can start effective CPR, because effective CPR keeps blood going to the brain. It's not just about surviving a cardiac arrest. It's surviving with a good quality of life where the brain was not deprived of oxygen and the person was not left in a vegetative state or with serious neurological disability. So in conclusion, a large proportion of conditions implicated in sudden cardiac death in the young can be detected or highlighted by the ECG. Apart from electrical diseases, the ECG is also effective in detecting athletes with hypertrophic cardiomyopathy. Contemporary criteria are associated with a significantly low false positive rate in white athletes, but the take-home message for all of you, a normal ECG does not protect from sudden cardiac death. Therefore, it is absolutely essential to have provision for CPR and rapid application of an automated external defibrillator. Thank you very much.
Thank you very much, Professor Sharma. Thank you so much. I'm getting a lot of comments coming in both on my phone here and on my screen. People are fascinated. Just in terms of questions, I think the chat box has been disabled, but people can put questions in the Q&A. Professor, I'd just like to ask you, you mentioned concerns regarding screening there and the high number of false positives. Would you think it's fair to say that there's a risk of creating unnecessary anxieties or worries amongst people because of this, and the need for additional testing? Then is that something we should be considering?
Well, certainly screening can cause false positive results, and that's why screening should not be done by any old person. They should be done by people who actually understand what happens to the heart with years and years and hours of exercise, because as the heart enlarges to be able to pump this cardiac output around the body for exercising individuals, there are changes in the electricity of the heart that need to be recognized. So screening should only be conducted by people who look after athletes and who are aware of diseases that kill athletes. They should not be relegated to individuals who just do general cardiology. I wanted to reassure all of you that screening was associated with a high false positive rate, but that's gone down to about 2.5% now, because we have worked very hard in refining how we interpret the athlete's ECG.
Brilliant. Okay, Professor Sharma, I see Philip Coffey, a solicitor here, is asking, is there research on any common signs or symptoms evident in the days or hours before an incident occurs?
There is indeed, not so much in young athletes, but certainly in the older athletes. These are people who are in their 40s and 50s who have had cardiac arrests in mass endurance events such as park runs or half marathons, that 1/3 of those individuals actually had symptoms suggesting that something was about to go wrong. They either had complaint of chest pain or were more breathless than they felt they should have been, or had palpitation. So my advice to all of those people is that if you're experiencing symptoms like that, you really must not engage in intensive exercise unless you've actually had a proper cardiac assessment. Now, by that, I'm not talking screening. Screening is to look out for someone who looks absolutely fine and saying, look, you may have something wrong with you. when you go to see your doctors, you're actually going to your doctors for an obvious problem. And that sort of problem really needs to be assessed before you start exercising vigorously again.
Thank you. Somebody asking here, how useful are MRI scans and Doppler ultrasound as part of cardiac screening?
Well, you see, when we do something called screening, we try to use the most cost-effective test. So you want to use your cheapest test that will pick up the largest number of people. Because if we start using lots and lots of expensive tests, then the screening is not cost-effective. Because if you're going to spend millions just to save one life, then people will argue that it's not cost-effective. So although an MRI scan is a very good tool, we don't usually use it to screen. We use it to investigate an abnormal ECG, but it is a very effective tool. And certainly some of the people that have had cardiac arrests, had they all had MRI scans, would have probably picked up things that the ECG didn't do so.
Brilliant. I'm getting a lot of feedback here that you've been absolutely excellent. Lots that people didn't know. Somebody asking, does a congenital heart disease in a baby who gets an all clear result in them being more likely to have a sudden cardiac arrest later on in their life, particularly if that person is an athlete?
Very good point. And you know, obviously there was a time where people born with serious congenital heart disease didn't survive to adulthood, but with good surgical techniques now, many of these people are operated on within the first week or two, and do go on to survive, and do actually go on in many cases to become good athletes. I look after several athletes who've got who have actually had repairs of serious cardiac diseases that are actually competing, some of them even in the Tokyo Olympics, in the Paralympics. But there is always that little concern that the increased load on the heart during that very vulnerable period as a child may have caused issues. So what we do for sure is that even though these people can exercise, most people that have got grown-up treated congenital heart disease should be tested every 2 or 3 years just to make sure that nothing serious has developed if they're competing at very high level. But if there is anyone listening here who has had congenital heart disease, this is not a license to say you shouldn't exercise. Everybody in the country should be doing exercise. I'm talking about vigorous exercise here.
And that's a very important point. I might just take one more question because we'll have to move on, but somebody's asking, would you recommend an angiogram as an annual good preventative test to detect heart disease after a certain age?
An excellent point. Obviously, when we talk angiograms, we're thinking needles into vessels of the heart, and it makes a lot of people squirm and get very worried. But certainly there are very good methods of doing angiograms now, which don't involve any needles. We can do something called a CT coronary angiogram, where you go into a CT scanner and we inject a little bit of dye into a vein at the back of your hand, and we can see the blood vessels of the heart. But I don't suggest that every single person that's running marathons who is aged 50 plus should have this. What we normally say is that if you habitually exercise and you've been exercising all your life, you've had no cardiac symptoms ever, you have had no risk factors such as you know that you don't have high blood pressure, you know you don't have diabetes or high cholesterol or family history, then you don't need any tests before you engage in these. But if you've got any one of these situations, then you should have an exercise stress test. But if you live in a country or if you've got the finances to do a CT coronary angiogram, then that is a better test than an exercise stress test to identify blocked arteries. Yes. Very
good. I'm just going to give you one more question. I apologize, Professor, before we let you go. They're still flying in. Roger Murray is asking, do elite athletes have a greater chance of survival due to high oxygen perfusion? He's given the example of Fabrice Muamba.
I think the main thing that makes a difference in an elite athlete surviving is the speed at which they are dealt with. And we saw on television, we saw the Muamba situation on television. Let's talk about the worst situation we've ever seen on television. I think it was the Marc-Vivien Foé case where he didn't survive. And that match was televised. His arrest was televised as well. And if you go back and ever look on YouTube, you will see that no one touched him for minutes and minutes and minutes. No one did CPR for 11 minutes. I remember watching in horror. But clearly, when you saw in Muamba's case, people did get to him quite quickly. I mean, he needed 36 shocks before he came out of it. And in Ericsson's case, it was even quicker. So I think it's the the real take-home message is that the quicker you get to an individual, the better. And of course, elite athletes are being watched by fans and by spectators and by paramedics. So they're much more likely to receive treatment quicker than the general population. That's what makes the difference.
Okay, it's nearly 11. I will let you go, I promise. But one more question. I think it's really important. Padraig Hoare from the Irish Examiner is saying, we were all horrified with the imagery we saw at the Euros with TV directors chastised for the seemingly egregious and intrusive pictures beamed into our living rooms. However, he asks, does such an event playing out in public actually help raise awareness? Sorry, now the question has disappeared, but I think you've got the gist of it. He's asking, does it actually help to raise awareness? I know there was a lot of criticism of BBC and other outlets, but can it be beneficial?
Well, it can be. I mean, it certainly disturbed a lot of people. I mean, I look after athletes all the time and certainly looked after the athlete in question. So it really did disturb me, and it disturbed a lot of people. These are role models that, people look upon, and you see something like a young man, breathing his last, who may not survive. It is very disturbing. But one thing that the media headlines did do, now I don't think that the TVs needed to focus on that, because the media would have done it for them the next day. There'd have been headlines everywhere. But one thing that these headlines did do, they increased the number of calls that cardiac risk in the young in the UK took. I think they took about 20,000 extra calls that week just after something like this. So I think what this does do is it basically makes people realize that they're not invincible. And I think it makes people realize that maybe we should all have a defibrillator. My wife was saying, shouldn't we have a defibrillator at home? And I said, why? She says, well, you never know what's going to happen. And it does get people thinking. I think every single school should have a defibrillator. It's so, that really is something that I would really lobby for.
Absolutely, that's fantastic. Well, listen, we have taken up a lot of your very precious time, Professor Sharma. I could go on all morning probably, but I won't. I will let you go with just a massive thank you from all of us for the wonderful work you continue to do and for being here present with us this morning. Thank you.
It's an absolute pleasure. Thank you for having me.
Thank you. All right. Well, I'm going to move on to our next speaker. You can continue to leave questions, comments, or feedback in the chat or the Q&A box and the chat box, which I think are both now enabled. That was very interesting. Our next speaker is one of our own. It's Dr. Conor Deasy. Conor is a professor of emergency medicine at UCC and Cork University Hospital, which is one of the busiest, if not, I think, the busiest emergency department in the country. Conor is also the Deputy Medical Director of the National Ambulance Service between 2014 and 2020. He is Chair and Clinical Lead of Ireland's Major Trauma Audit, the National Office of Clinical Audit, NOCA, you can look that up. And interestingly, he was also awarded a PhD for his work in out-of-hospital cardiac arrest. So it is an issue close to his heart. So with that, I would like to invite Dr. Deasy on screen.
Thanks, Doireann, and thanks everybody for tuning in. I'm very happy to take questions from anybody who might have questions or concerns that they might want to put on the panel. And Doireann, maybe if you fed those through to me. I suppose the key message that I wanted to deliver today was to encourage you all to do CPR, to get a class in CPR if you haven't done so already. But by starting CPR on a patient who has collapsed, you can't do any harm. And you double or possibly even triple a person's chances of survival. And by doing a CPR class at any time in your life, obviously the more times you do these things, the better. But by doing them at any time in your life, you are 10 times more likely to react in an emergency. You won't be scared. You won't be paralyzed by fear. You will know what it is that you need to do. And of course, one of the first things you will need to do is dial 112 or 999. And once you do that, the person on the other end of that call, the call taker, is actually going to talk you through everything that you need to do to deliver chest compressions and to deliver them effectively. So at the moment in Ireland, our rate of bystander CPR is excellent. It's really good. Now, it could be better. It's 84%. So that is in large because we have call takers in the National Emergency Operations Centre who take that 999 call or 112 call, and as soon as they realise that this is potentially a cardiac arrest, and they ask you a series of questions to figure out whether the person who has collapsed is responsive and showing signs of life, they will establish whether it's appropriate for them to instruct you to crack on delivering chest compressions. So if you've never done a CPR class in your life, these folks at the other end of this phone will be able to instruct you on what the right thing to do is. And as I say, in somebody who is collapsed, lifeless, you're not going to do any further harm. You can only do good. And as I said, you double the chances, possibly even triple the chances of survival. 70% of cardiac arrests actually happen in the home. I'm chair of the Out of Hospital Cardiac Arrest Registry in Ireland, and we took a look at young adult cardiac arrests. So those are in the ages of 18 to 35. And in that age group, about 5% happen in recreational or sports places. 70% happen in people's homes. So the reality is that you're likely to be doing CPR on someone you love and someone who's dear to you and close to you. And so again, another reason to go and do a night class or get a class in CPR. The other key message I suppose I wanted to highlight was there are AEDs, as Cathal said, scattered all over this country now at this stage. And one of the challenges we have is making sure we know where the AED is located. And similarly, that so if it is that there's an AED down your corridor at work, or in the dressing room on the GA field, or in the dressing room on the rugby field, or outside the church gate, you need to know that because as soon as chest compressions are started, you've called. As soon as you've called 112-999, chest compressions are started, what you really want is early defibrillation. And while we're great at bystander CPR in Ireland, 84%, we're not so good at getting that defibrillator to the patient in a timely manner. So when our National Ambulance Service paramedics arrive, in about 25% of the cases that they arrive to, there's a defibrillator on site. And ideally, you would want that to be greater. You would want it to be up and around the levels of bystander CPR rates that we're experiencing at 84%, as I said, in Ireland, or higher. So knowing where the AED is very important. And as Cathal highlighted, it's not just important that the AED looks pretty, it's important that it's serviced regularly as per manufacturer guidelines, so that it is ready to act and to operate when you need it to. So a lot of you out there may be involved in clubs and societies where there are AEDs, and you might take away from this talk the need to make sure that it's in service. One of, as Doireann mentioned to you, I did a PhD in cardiac arrest, in out-of-hospital cardiac arrest, and one of the studies I did was looking at cardiac arrests in young people. Now, this was in Australia, in Melbourne, and I looked at cardiac arrests that happened in young people, and I was able to look up their coroner's reports. In Victoria, they have a statewide registry of all the autopsies that were done, and what was remarkable was we looked at cardiac arrests where Ambulance Victoria, the ambulance service there, responded and performed CPR. And then we looked at those who didn't survive. So about 13% survived, 87% didn't. And I went and then looked up their their autopsies. And I looked at around 550 autopsies at that time. And what was remarkable was 40% of those young adult cardiac arrests were due to heart problems. 38% were due to problems that weren't associated with the heart, in fact. And they were problems like sudden unexplained death and epilepsy, massive pulmonary embolism, pneumonia, mixed overdoses of opioid drugs largely, subarachnoid hemorrhage, which is a massive bleed in the brain, and so on. Of those in young adults that were associated with the heart, by far and away, the most common was ischemic heart disease. And Professor Sanjay referred to ischemic heart disease during his talk, where he described narrowing of the coronary arteries. And I'm sure Nick Flynn, Dr. Nick Flynn, the GP who's on this call, will reference the cardiovascular screening that goes on to establish whether patients have ischemic heart disease and how to prevent patients developing ischemic heart disease. So of the 40% of young adult cardiac arrests that were due to a heart problem, 51% were due to ischemic heart disease. And then after that, it was cardiomegaly, which is an enlarged heart, cardiomyopathy, congenital heart disease. These were all small single-digit percentages as the cause of the out-of-hospital cardiac arrest. So this again speaks to the fact that these incidents are very difficult to predict. So, and Professor Sanjay has done phenomenal work in terms of identifying risk factors for people who are involved in sports, but we all acknowledge that despite everybody's best efforts at screening people for the potential for cardiac arrest, it is still very difficult to screen and identify people and identify risk factors with accuracy. And so again, we need to be ready with our ability to do CPR and access an AED and access emergency services for when that person suddenly collapses. Because as I said, screening is great, but it's only so good, and we need to be prepared as a society. We need to be prepared for when that person collapses, that we know that we need to get down on the chest and do CPR. So they're my main messages for today. As I said, I'm very happy to take any questions or answer any queries any of you might have that relate to the emergency services, the ambulance service, or the emergency department. So thanks, Doireann, for giving me this opportunity to speak.
Thank you so much, Conor. It was brilliant listening to you. And I think anybody who has had to liaise with paramedics, ambulance personnel, or has had a loved one in the emergency department will appreciate the invaluable work that you do. And that just has to be recognised. So loads of positive feedback flying in for you. Niall Hill is asking, I've heard some AEDs also have a diagnostic element to them and may not shock unless a problem is detected. Is this true?
Yeah, that's a really important point, and thanks, Niall, for bringing it up. So an AED is a sophisticated piece of equipment that will read the underlying electricity of the heart. So if the patient is in what we would term a shockable rhythm, which is what Professor Sanjay described in terms of ventricular fibrillation or ventricular tachycardia, which is a shockable rhythm, then the AED will deliver the shock. If the patient isn't in a shockable rhythm, in other words, they're in cardiac arrest, they've got a cardiac arrest that is not shockable, then the AED won't deliver a shock. Or similarly, if the patient has in fact got a beating heart, but you don't realize it, the AED isn't going to deliver a shock. So the AEDs are foolproof. They're sophisticated. They're designed to be really easy to use. Essentially, you just turn it on and listen to the instructions that the AED give. And about 15% of cardiac arrests in Ireland that the National Ambulance Service respond to are shockable rhythm cardiac arrests. by the time the ambulance gets there. Now, many more may have been shockable if the ambulance service had been there within the 3.6 minutes that Professor Sanjay described, okay? But of those that the ambulance service responds to, and we respond to 2,500 cardiac arrests per year where we start a resuscitation, of those 2,500 per year, about 15% are a shockable rhythm cardiac arrest. And as I said, a defibrillator is foolproof, really. They're very easy to use. They're designed to be easy to use, and they won't deliver a shock unless it's indicated and unless it's safe in terms of the patient. The patient isn't going to get a shock unless they need it.
Very good. I think you've answered another question in here, which is, can we do any harm by wrongly attempting to use the AED? So that's great to know that they're actually foolproof. And I think it will almost coach you as to what to do when you get one. So that's am I right in saying that, Conor?
You're absolutely right, Doireann. And that's another advantage to doing the CPR class, because you really, when somebody collapses in front of you, as I said, it's going to be a loved one, you are going to be very stressed. And it's not the time, you know, you're not going to be working with your full capacities. And so getting familiar with this kit, with doing chest compressions, with hearing an AED give you instructions, with, you know, turning on the AED, getting familiar with that by doing a CPR class is really very helpful, vital really. And the more people that are out there, the more people you can bring along with you to having that CPR class, the better. Make it a social event. Gather the troops and bring them along. And Croí are obviously excellent at promoting, the Irish Heart Foundation are excellent at promoting these classes, and you'll find access to these classes on these websites and in many other destinations.
Brilliant. A comment just here in from Colette. She says, I believe there's a project underway to record where the AEDs are located around the country. There's a website for that. It's aed.rescue.ie. And she says the idea behind that is that the National Ambulance Service will be able to tell people where their nearest AED is to them. So what I found very comforting, Conor, was that, you know, you say you can't do any harm. And I suppose for me, what you say makes a lot of sense. It's about getting the training, make it a social occasion, you know, team up with friends, go and do it. Renew it, you know, update the training every few years, keep up to date with the training. Because just a thought that I had, if somebody were to collapse before me, say on the street or, you know, somewhere socially when things reopen again, I feel that there would almost be a fear of jumping in and doing chest compressions while we're waiting for the ambulance to arrive, for fear that, you know, I might do more harm than good. But the message that you're clearly stating today is that, you know, with the CPR and with the defibrillator as well, you can't do any harm. You can, yeah, all you might do is save a life.
Absolutely, Doireann. You can't do any harm. And the other message is that the ambulance call taker will be there holding your hand as you do CPR. So put the phone, your smartphone, on loudspeaker, put it down by the head of the collapsed patient and listen to the instructions. And the ambulance call taker will stay with you while the ambulance is getting to you. Brilliant. The other big thing, actually, for those of you who want to even get more involved, there are community first responder groups set up all over the country. Before COVID, there was about 275 community first responder groups. And these are networks of people located in villages and towns, in communities across the country who are activated to cardiac arrests in their area via text message from the National Emergency Operations Centre. And this is fantastic work that these people are doing. They provide training, they provide a community of people, because it is very traumatic for those that attend a cardiac arrest for the days afterwards, wondering if they did all the right things. So there's support networks. They're supported by the National Ambulance Service and community. There are community support officers within the National Ambulance Service that support these community first responder programs. They took a hit during COVID, and things were stood down, and over the coming weeks, we would hope that they would be back up and going, and we would encourage people to be involved and to support their community first responder groups on their various fundraising efforts to buy AEDs and so forth.
Brilliant. Again, just lots of thank yous coming in, Conor. Somebody asked, would you like to see school children having this as part of the curriculum? I presume that means
yeah. So obviously, Professor Sanjay has strong views on AEDs being put in schools, but whatever about that, I'd be very keen to have children be able to perform CPR, because whilst they might not ever have to deliver it as children, they'll bring it with them into adulthood. And there's all sorts of concerns that people might have about children learning something that is so traumatic. It's how it's thought. It doesn't need to be traumatic, and it can be thought in a very positive way that is attuned to the psychology of children. And obviously you want to get them at that right age. And there's a literature out there, and the Irish Heart Foundation, I know, have gone into schools, and I'm sure Croí are involved in this as well, teaching CPR. And I think it's a wonderful thing to teach our kids.
Fantastic. So while we wait for you to come on scene, we must do the best we can as lay people and members of society. I think that's the message I'm very much getting from you. Just one more question, maybe, Conor. Annie's asking, is there good and bad CPR? In other words, is the technique important? If you haven't been trained, you won't have a technique. That's what she's asking about.
Yeah, so certainly there is good and bad CPR, and obviously it's better if you do the training and get learn how to do it from an instructor. But to be honest with you, there has been a lot of work done on how to get people to do effective CPR by instructing them over the telephone. So these call takers have very specific narrative, very specific words that they instruct you with, and what we find is that any CPR is better than no CPR, and obviously good CPR is better than bad CPR, and your chances of delivering good CPR are much enhanced if you go and do a class.
Brilliant. Well, we've all heard that.
Bring your friends, and bring your friends.
We'll all go together, COVID permitting. Before we let you go, is that actually a defibrillator behind you on the shelf? Sorry for being so nosy.
Yeah, it is. We have a changeover of staff happening on Monday morning, and we need to show them how our defibrillators at CUH work. This is actually a Phillips defibrillator. So it's not meant to be product placement, but that's a Phillips defibrillator. And we need to instruct all our new doctors on how to use them and be familiar with them when they change over on Monday. So sorry, yeah, well spotted, Doireann.
Yeah, well, thanks so much. It's great to see one and see the size of it, Phillips. Listen, Conor, everybody's just saying a huge thank you to you. We know you're extremely busy and you're doing wonderful work for the people of Cork and beyond out in CUH. So thank you for that. Thank you for everything that you've shared with us, and we really appreciate it. Thank you, Conor. I suppose at this point in time, maybe we've been sitting for a long time. It might be a chance for participants to just take a little, very short comfort break. If you maybe want to get up, stretch the legs, have a glass of water for the sake of heart health. So we might just pause. We might just pause for 2 minutes, just 2 minutes before we resume with our next speaker. So welcome back. Hope everyone had a chance to stretch their legs. We're going to jump straight back into it because we are running slightly over time already. We've heard from wonderful speakers this morning, and our next speaker is, again, fantastic. He's well known around Cork, Dr. Nick Flynn. He's a graduate of medicine in UCC. He's also senior partner at Cork's largest GP practice, mycorkgp.ie. They have, I think, 5 clinics across the city now, is that right?
Yeah,
5. And a huge support staff. So Nick has worked in Cork prison. He's done a huge amount of work in the area of addiction and recovery. He's over 15 years experience, and over the years he's actually worked as a team doctor for local GAA and soccer teams as well. So he knows a lot about the subject. We're delighted to have him here. And with that, I will hand you over to Dr. Nick Flynn.
Thanks, Doireann, and thank Croí as well for the invitation to talk this morning. So my talk is called Pre-Exercise Who Knew. So I'm basically talking this morning about pre-exercise assessments and risk management, but particularly those assessments where they occur in the community. So the majority of people, I'd say, who exercise are clearly not elite athletes, and the majority of people who exercise do so probably casually: walkers, runners, joggers, cyclists, swimmers, the five-a-side soccer players, the hill walkers, and these people don't have the infrastructure provided by sports clubs, and very often approach general practitioners for advice in that regard. So there's 2 questions which your GP loves to hear.
I just interrupt for a second, Nick. I'm so sorry to do this. I'm just cutting across to you very briefly. The sound is coming in and out ever so slightly now. Maybe that's just me. Just check that everything is in working order.
I'll just try it with
perhaps it's just at my end.
That better?
Yeah, that seems much better.
Thanks for that.
Great, great. Sorry to interrupt. Thank you.
Yeah, okay. So with humor, timing is everything. So the joke was interrupted by the by the sound. So the first question that your GP doesn't really love to hear was how much do I owe you, doctor? And one of the difficulties with the online environment and online webinars is I can't tell if anybody actually found that was funny. So the 2 questions which your GP loves to hear. We get a lot of inquiries from people that are undertaking exercise programs that are going off on endurance activities, and they want us to sign medical certificates to say that they're fit to partake in this activity. So I'm going to, I suppose, talk about how we approach those issues, and then just briefly at the end, the other thing that we are seeing a lot of at the moment is there is, as Dr. Sanjay alluded to, there are formal pre-exercise screening programs. There are a number of companies in Ireland who provide those. And as patients' GPs, we often get requests from parents to explain what might happen during those, and is it something that the children should attend. So we'll go to those questions. So exercise, why bother? Well, clearly exercise is a very healthy activity. It is important for primary prevention of illness. So primary prevention basically refers to preventing an illness before it happens. So there are over 35 chronic illnesses that being physically active is important to help you prevent. These include obesity, diabetes, high blood pressure, stroke, heart attack. There are many illnesses that by being physically active, we can prevent ourselves getting as we get older. Also, if we become unwell and we're unlucky to develop a chronic illness, exercise is an important treatment modality for that. So if you get a chronic illness and you exercise, you're likely, it is likely that you have better outcomes. And finally, it's good fun. And I suppose that alludes to what's very often maybe a hidden chronic illness, which is our mental health, and exercise certainly is helpful in that regard. And I would have seen a lot of people throughout the pandemic and throughout lockdowns who found exercise was very important for their mental health, and you could see very much that they were struggling if they developed an injury and they were unable to exercise. So if exercise is so healthy and so important for us, why are we considering doing pre-exercise assessments? And Dr. Sanjay's talk very much spoke to this. It was very helpful. The three-letter acronym that's used in this regard is PPE. We've all become used to PPE over the last 18 months as personal protective equipment, because first of all, we didn't have any of it, and now we've got so much for finding it difficult to store. But in this regard, the PPE we're talking about is a pre-participation evaluation. So the pre-participation evaluation, what are the objectives of this? So when somebody comes and they look and you're giving them a checkup, I suppose, before the exercise, what are we trying to achieve? The first thing is that we want to screen for conditions that may be life-threatening or disabling. The second thing is we want to screen for conditions which may predispose to illness or injury. The secondary objectives then would be, it's a good opportunity to engage with somebody about their general health, and it's a very good opportunity to take for a health promotion. So this can be when somebody comes in and they're thinking about, maybe they're taking up cycling, they're going to a gym, the gym wants them to have a medical before they start. It's a good opportunity to remind them that smoking is unhealthy, that it's important that they manage their weight. If they're female in the age of having a smear test, make sure that their smear tests are up to date. So it's a good opportunity to engage in health promotion activity as well as the general checkup. So when we think about that and we think about, look, the healthcare service is clearly under a lot of pressure, general practice under a lot of pressure. GP appointments are fairly precious. We don't want to create a lot of unnecessary work within general practice that doesn't have any, I suppose, improvement in outcomes for patients. We don't want to create work that doesn't actually improve the health of the nation. So what we would like to do is make sure that people who are coming for the pre-participation evaluation are people who actually genuinely need it and will benefit from it. The American College of Sports Medicine in 2014 gave us some guidelines in this regard. They suggest that we should look at three principal factors. The first one is the current level of physical activity that the person is partaking in. The second one is the patient known to have cardiovascular disease, metabolic disease, or renal disease? Or if they're not known to have those diseases, do they have signs and symptoms which are very suggestive that they might have those diseases? The final parameter that they would ask us to look at is, what is the desired level of physical activity that the patient wants, that the person wants to attain, wants to strive to? Basically, if you take those three questions, the first one being, does the patient participate in regular exercise? When the answer to that is no, if you look over onto the left-hand column, so they don't exercise and they don't have any pre-existing cardiovascular, metabolic, or renal disease, and they have no signs suggestive of cardiovascular, metabolic, or renal disease. Well, the American College of Sports Medicine suggested that in this situation, medical clearance is not necessary. The person can proceed to light to moderate intensity exercise and can gradually proceed to vigorous intensity exercise. So that speaks to what is light to moderate intensity exercise and what is vigorous exercise. So light to moderate intensity exercise really is your aerobic exercise, and your moderate to vigorous, your vigorous or highly vigorous intensive exercise is that more intense exercise where lactic acid production is made in the muscles and you get anaerobic metabolism in the muscles. For you and me, when we're exercising, what does that mean? Really, it's a function of our target heart rate. So we can calculate our target maximum heart rate as 220 beats per minute minus our age. And then it's as we approach that, the intensity of the exercise we're doing is becoming more intense. So clearly, light and moderate intensity exercise, you're at a lower percentage of your maximum target heart rate. And then vigorous and highly vigorous, you're approaching that target heart rate more. So then if you move into the middle column where the patient or the person has known cardiovascular, metabolic, or renal disease, medical clearance would be recommended in that regard. Or following medical clearance, the person can proceed to light to moderate intensity exercise and may gradually increase. the intensity thereof. And finally, if the person does not have established cardiovascular, metabolic, or renal disease, but they have signs and symptoms of that, again, a medical clearance or a pre-participation evaluation is recommended. So then if you go on to the next situation, which is where the patient or the person is already exercising. So if they're already exercising and they want to increase the level of intensity of their exercise, when there's no pre-existing cardiovascular, metabolic, or renal disease, no signs of that, medical clearance is not necessary, and the patient can proceed to increase the intensity of their exercise without medical clearance. Again, come into the middle column where they've known cardiovascular, metabolic, or renal disease, and they're already exercising. You don't need medical clearance to continue on their current level of exercise, but if they want to increase, they should have a medical check, and then they can continue with moderate intensity exercise and increase that to high intensity as they want to do themselves. The final column is, I suppose, where it becomes a bit more tricky, where they don't have established cardiovascular, metabolic, or renal disease. They're already exercising, but they have the symptoms or signs suggestive of cardiovascular, metabolic, or renal disease. These patients should consider stopping exercising and having a check before they continue with their exercise programs. So that begs the question, what is involved in the medical assessment? So when patients come to us for medical assessment, generally they'll have the consultation involving their previous history, their family history. But when it comes to the actual check itself, the basics of the check will involve the blood pressure test. The blood pressure we all be familiar with. Frequently, patients with blood pressure don't have symptoms. Having high blood pressure would not preclude somebody participating in physical exercise. But if it's very high or severe high blood pressure, you would ask the patient not to participate in vigorous exercise until that blood pressure was under control. Next, we would be looking at the heart rate and rhythm. Again, Professor Sanjay alluded to this earlier. A normal heart rate is under 100 beats per minute. Again, patients who are physically deconditioned and not very fit, they may have a resting heart rate of over 100 beats per minute. Again, it wouldn't be a contraindication to them carrying out physical exercise, but again, until their fitness levels improve, you would probably ask them not to carry out vigorous physical exercise. And the rhythm of the heart, again, is very important. The most common irregular heart rhythm we see in general practice in screening programs is atrial fibrillation. And again, it's not a contraindication to physical exercise, but you would ask the patient not to participate in vigorous physical exercise until he was on, or she was on appropriate treatment. Body mass index, that's your height and weight as a ratio of each other. Again, people who are overweight, again, will not be asked not to exercise, quite the opposite. We would increase to exercise, but avoid vigorous physical exercise until the fitness levels increase. Analysis of the urine, giving us a steer towards metabolic disease, if there's sugar in the urine, or renal disease, if we've got protein or blood in the urine. Listening to the heart sounds. Listening to the heart sounds gives you extra information from the checking the pulse. So listening to the heart sounds, you can get ideas of the structural abnormalities in the heart, particularly valvular abnormalities. Are there any signs of Marfan syndrome? Marfan syndrome is a relatively common genetic inherited condition, and patients with Marfan syndrome are more prone to a condition called dissection of the aorta, which can happen as more likely to happen with increases in blood pressure or heart rate, which can happen during vigorous physical exercise. Visual acuity, I put in, it's not part of a routine check that I would do pre-exercise unless it's on a pro forma or a form that the patient has brought with them. But in several American studies, the most common abnormality picked up at pre-participation evaluations is actually abnormal blood pressure and abnormal visual acuity. And finally, as Professor Sanjay alluded to or mentioned earlier, the physical examination with the measurement of electrical activity of the heart and ECG has been shown to be more effective than physical examination alone. And again, the 12-lead ECG, as Professor Sanjay mentioned, is a very simple near-patient test done in your GP office, and it's it's not expensive, and so therefore it does fit a lot of the criteria that we would want in a screening test. We will very rarely do blood tests unless there is signs and symptoms suggestive of a cardiac or metabolic, say a cardiac risk factor or a metabolic disease like diabetes that we wanted to rule out. So you can see from that list that it's quite an extensive list. It's not something that you can do, on the cuff in 15 minutes if you're not prepared for it. You'll quite possibly get through most of it with a doctor and a nurse both working for 15 minutes, but certainly it's something that you're better to know in advance. So if anybody is going or making an appointment with their doctor for a pre-participation evaluation, it would be good to let their doctor know that this is what the full purpose of the visit is, so that the doctor can make appropriate, I suppose, time arrangements for that. So very quickly, I just want to show you a very common pre-participation evaluation that we do in my part of town up in Hollyheaney, and it's for the Irish Amateur Boxing Association. So this form is actually a slightly older one, so it's not one that's currently in use, but the current one, we get a feel for what the doctors are asked to do I suppose, complete this form and to screen the patient. So you got the patient demographics, family history, and past medical history. Again, we were talking about that earlier. Is there a previous medical condition that makes exercise we want to be aware of if this patient is entering into an exercise regime? And similarly, is there any family history, particularly in relation to cardiac issues, that we should be aware of? The past obstetric and gynecology history, this clearly is their form for a female participant. So height and weight, BMI, we've mentioned urinalysis, we've mentioned cardiovascular exam, the heart rate and rhythm, the blood pressure, listening to the heart for structural abnormalities that can be picked up from auscultation, particularly aortic stenosis, chest deformities, lung deformities, very important. In all exercise regimes, particularly boxing, that the upper limbs and soft tissues are all functional and no abnormalities. Any hernia, the central nervous system exam, visual acuity, and a look at the fundi. We actually had a young patient recently who had a normal pre-boxing medical, and unfortunately got a significant head trauma and had bleeding in both eyes, which required hospitalization. So ears and hearing, genital immune system, clearly pregnancy is not something that you want people or your female patients to be boxing with. Any breast problems, signs off. So again, you get an idea that it's not a straightforward consultation. It's something that takes a little more time than a regular consultation. Again, just to give the GP some heads up that this is what's the purpose of the visit. So very quickly, the Medical Protection Society has asked doctors to be cautious when declaring patients fit to run marathons and participate in other vigorous forms of physical exercise. Interestingly, they suggest that GPs should consider the information they have on the patient's current and past medical history, which may be relevant to the event, and state that there are no known health conditions which render the patient unfit to participate. So it's like stating the negative. So there's no reason I know why the patient cannot do this, rather than saying I'm certifying the patient can do it. So finally, then, if you go back to children attending cardiac screening programs in schools and in sports venues, and again, we get a lot of queries from parents about this because they want to make an informed choice for their children before they go. And again, Professor Sanjay's talk alluded to this, that it should be done by appropriately trained professionals, and the companies in Ireland really do provide a good service, I would say. But basically what the screening process looks like, step one is your questionnaire, frequently filled out online before the physical checks are done. Again, they ask about current levels of physical activity, the future levels of physical activity, medical history, person to the patient, family history, and there's a symptom checker, followed then by a physical assessment, which very often is performed in groups. So the companies come on site, and they might do 20 or 30 screens in a day, measuring the blood pressure, the BMI, the waist circumference, heart sounds, heart rate, rhythm, again, the electrical activity of the heart ECG. This information is then algorithmed and normally sent on to a consultant cardiologist, and again, Sanjay, a cardiologist who has an interest in sports and exercise medicine, and that cardiologist then advises if further tests or further investigations might be needed in any particular case. So that's me. So just, I suppose, in summary, physical exercise is clearly a very healthy activity. Not everybody who engages in physical exercise will need a checkup. That if that was the case, we probably would have to close all other episodes of care and just do physical checks for people who are exercising. But if you are attending your GP for a checkup for a pre-participation evaluation, that you should let them know in advance. That's the purpose of the check, so the GP can make appropriate time and I suppose personnel available, whether it's a practice nurse or a phlebotomist or whoever it is, would help them with the examination. So thanks very much.
Thank you so much. That was really interesting. Loads of positive feedback coming in here. Just one point to mention, and it's good. You can understand your risk factors for heart disease and stroke by checking out some of Croí's educational resources, and they're available on the website for anybody and everybody to have a look at. So that's a great resource there on Croí's website. A question has come in here. If a patient has known cardiovascular, metabolic and renal disease, does this make them more susceptible to having a serious problem? Are they classed as para-athletes?
Okay, so two parts to that question. One is if somebody has an existing cardiovascular, metabolic or renal disease, are they at risk of an underlying problem? The answer to that most probably is yes. But I suppose that's the importance of maintaining contact with your treating general practitioner and specialist for management of those chronic conditions, because that's the nature of chronic conditions, is that that we develop complications from them. So and the goal of treatment for most chronic conditions is to minimize complications. So it's minimize end organ damage and to improve outcomes and improve quality of life. The second part of the question is somebody with cardiovascular, metabolic, or renal disease qualified as a para-athlete, and my Reader's Digest opinion is that no, it doesn't, that a para-athlete has a different definition, which I don't know off the top of my head, but if anybody in the audience or if any of the other speakers knows the definition of a para-athlete, I'd be happy to hear that. But no, I don't think that would fit the definition. I think in general, Paralympians have disabilities. The definition of a disability is the inability to perform a task compared to an age and sex matched peer. So it's something that in general practice actually we have a lot of interesting discussions and discourse with patients with, because somebody who is blind is clearly disabled, but somebody with diabetes, for example, may not be, because although they have a chronic condition, their actually ability to perform tasks is not limited by that condition. So just by the fact that you have a chronic medical condition does not make you de facto disabled.
That's a really good point. I really like that. Just then generally as well, while we have you and your expertise, what sort of lifestyle changes would you recommend people adopt generally to look after their hearts?
It's a great question, right? So, and we get lots of, like, one of my pet hates is as somebody comes in with, and they're waiving a private health screening result that they've paid €400 for with a private provider, but and they want to kind of go through it, but it's never dawned on them to stop smoking. So it's what we do to stay healthy is not new. It's actually very old, right? So it's your diet, your exercise, your weight, your consumption of alcohol, not to smoke. It's to look after your mental health. So that, and exercise is a very important part of that, but also is the about the correct balance between work family and social life. For mental health, we're, like human beings, are social animals. So we need to maintain good relations with those who are close to us. And that would, like, if anybody asked me for advice on that, that's where it would be. You need to, of course, there are modifiable risk factors: your blood pressure, your cholesterol, your blood sugar. They're all very important. And a checkup with your doctor, especially over the age of 35 or 40, is no harm doing that. But the real meaningful changes that we can make are ones that we don't need to go to the doctor for, and they're like, or weight, or alcohol, tobacco, right? But the mental health is very important in that.
Yeah, I like that. So I suppose, what is the phrase? Mens sana and corpore sano, isn't that it? A healthy mind in a healthy body. So we'll all be very conscious leaving here today of dietary and lifestyle choices and maintaining regular aerobic exercise, and of course, as you said, not smoking. So Dr. Nick Flynn, thank you so much for being here with us, and we really appreciate it. And I'm now going to invite on our next speaker, who is Dr. Chris Danbury. Dr. Chris Danbury is a consultant in intensive care medicine at the University Hospital in Southampton. He studied medicine at St. George's Hospital Medical School, qualifying in 1990, and trained in anaesthetics and intensive care medicine. After a stint over in Australia, he took up the post of consultant at the Royal Berkshire Hospital, and after 18 years, he moved to University Hospital Southampton. He also has been offered a visiting fellowship in health law by the University of Reading, and he's a qualified mediator, and he is an excellent expert witness. So with that, I will hand you over to Dr. Chris Danbury, who will talk about his job, which begins when everybody else's ends.
Thank you very much. Right, I'm going to try and tell you what I do for a living, which encompasses what happens when everybody else has successfully resuscitated somebody. So we've talked about this chap earlier on, and we've talked about the fact that he had a cardiac arrest on the field and he got return of spontaneous circulation. Now, when he gets to hospital, everybody else leaves, and my job as an intensivist begins. What am I really interested in? So there are two things that I'm really focused on in terms of resuscitation and post-resuscitation care. One is the heart, but more importantly for me is the brain. So let's talk about brain injury. We've talked an awful lot about heart, but let's talk about brains. Hypoxic brain injury occurs quickly. It occurs in about 7 minutes. One of the questions earlier on in the morning was, if you're a fit, healthy athlete, do you have any additional reserves? The answer to that is no. Brain metabolizes aerobically. It has no ability to metabolize anaerobically, which means it's completely dependent on an oxygen supply, and it can't provide energy to nerve tissue without that oxygen supply. What do we mean by that? Well, this is a complicated slide, but I'll take you through it very quickly. So the average person's brain requires about 49 mils of oxygen per minute. In your blood, there is about 17 mils of oxygen for every 100 mils of blood. That's in your arteries. Your cardiac output is about 5 litres a minute, of which about 15% goes to the brain. So that's about 1.5 litres of blood to the brain per minute. So normal DO2, which is delivery of oxygen to the tissues, normal brain DO2 is about 250 mils of oxygen per minute. So you can see that that's about 5 times what you need to maintain cerebral oxygenation. Now, the amount of oxygen you use depends on a variety of factors. So interestingly, thinking hard will increase your oxygen requirement in your brain. And there have been studies that have shown that very nicely. Fitting will also increase the cerebral oxygen requirement. So what happens in a cardiac arrest? Well, first of all, we get a potentially primary brain injury. If your downtime before return of spontaneous circulation is 7 minutes or more, or can be less if you've got things like cerebrovascular disease, which impair blood supply to the brain, then you will suffer a brain injury, a primary brain injury. And that's will be picked up, first of all, in the watershed areas of the brain. So there are various different arteries within the brain itself that have a variety of different names. So the anterior cerebral artery, middle cerebral artery, posterior cerebral artery. And there's an area of brain between those different arteries, which has not an impaired blood supply, but a reduced blood supply. And those are known as watershed areas. And those areas of the brain are most susceptible to hypoxic damage. So those are the areas that tend to be affected first. That occurs at the time of cardiac arrest, assuming that you cannot deliver the 50 mils of oxygen per minute to the brain. If you've got good quality CPR, then you'll be able to do that. If you've got good quality CPR and you're giving supplemental oxygen, then you can very much do that. If, however, you suffer a primary brain injury, even a very modest one, then you're at risk of secondary brain injury. And the way I explain this to relatives of my patients is it's like having a bruise. So if you injure your thigh, if you hit your thigh hard, then you think, ow, that hurts. That's the primary brain injury. That's the primary injury. The secondary injury is the bruise that starts to develop over the subsequent few hours. And the brain is no different. So if you injure it, then you will get a secondary brain injury as it starts to swell. And there are various different things that we can do to minimize that secondary brain injury. TTM and TTM2 are two recent studies. They're called targeted temperature management. And what they've shown us is that avoiding pyrexia is probably a good thing and probably minimizes secondary brain injury. Also controlling carbon dioxide levels in your blood, nursing you slightly head up, ensuring proper oxygenation, ensuring proper fluid balance status, all minimize secondary brain injury. We can't absolutely prevent it, but what we can do is minimize it. So primary brain injury occurs at the time of the arrest. Secondary brain injury occurs on my intensive care afterwards. And recovery from brain injury can take a long time. So how do we know who's going to get better and who's going to get worse? Well, we're going to move on to Neuro Prognostication. And these are two CT scans. And the important thing here is the one on the left is pretty normal. And you can see that there are different shades within that CT scan. And that's called gray-white differentiation. So there's gray matter and white matter. So that's myelinated parts of the brain and unmyelinated parts of the brain. And in a severe brain injury, you get loss of gray-white matter differentiation. So the myelin goes and the brain stops working. So the brain on the right-hand side, the CT scan on the right-hand side, shows that loss of gray-white matter differentiation. And the thing that I really wanted to pick out here is to show that it's a global effect. So when you are starving the brain of oxygen for a prolonged period of time during a cardiac arrest, it produces a global effect on the brain. It's not isolated to one particular area, unless that area has got a critically impaired blood supply anyway. So you're now on my intensive care unit. Well, I hope you're not, but your relative or somebody you know is now on my intensive care unit. How do we determine what's going to happen? Well, this is deliberately an incredibly complicated slide, and it's the sort of things that I will do, and it's the sort of things that I will investigate and look at and try to determine whether the patient is likely to make a good recovery or whether they're more likely to make a poor recovery. I'm not going to dwell on this. It's just really an illustration. But what I wanted to come on to was this, which is the predictors have low sensitivity. There is a risk of bias, substantial risk of bias within those different predictors on the previous slide. And the bottom line is it's difficult and complicated. And it's really hard to determine whether somebody is going to make a good recovery or a bad recovery. And what do I mean by good recovery or bad recovery? Well, this is the end point. This is the Glasgow outcome scale. It's an extended scale. And you can see at one end of the spectrum, we have death. And at the other end of the spectrum, we have fully returned to a normal life. Most people who come to intensive care following a cardiac arrest will fall, well, they're less likely to get to 8 fully returned to a normal life. There is normally some degree of deficit. Within the lower end of the scale, at vegetative state, you've also got to remember that there's minimally state plus, minimally conscious state plus and minus, MCS plus and MCS minus. And this is a state where you are just about aware of what's going on around you, but you find it's very difficult to actually interact with your environment. And that's a really, having seen patients in MCS, that's a really, really horrid end place for people to be. So the end result of all of this neuroprognostication is I don't know what's going to happen to a patient who's admitted to my intensive care unit on day 1. I don't know whether they're going to die. I don't know whether they're going to make a full recovery. I don't know whether it's going to fall somewhere in between. Most likely it will fall somewhere in between. So because of that, we now need to make decisions about what to do, how to treat the patient, whether a patient who is in ICU, has been in ICU for a couple of days, we should continue life-sustaining treatment, that we should continue active management, or whether we should stop life-sustaining treatment and stop active management. So how do we make those decisions? Well, I'm delighted that you have the Assisted Decision-Making Capacity Act 2015. Now, I'm not going to bore you with my pet love or hate, the Mental Capacity Act 2005, which applies to England and Wales. But the reason why I'm really pleased about your act is that it builds on this declaration from the United Nations. So this is the United Nations Convention on the Rights for Persons with Disabilities, Article 12, Paragraph 4. And it stresses that we should be looking at the will and preferences of the person who lacks capacity. Now, I should add that most patients on intensive care, and when I say most, I'm talking about 80 to 90% of patients who are being treated on intensive care will lack capacity, both litigation capacity and also capacity to make decisions about themselves. And the reason why I flagged this up is that in your act, you also talk about the will and preferences about medical treatment decisions. And I think that's a much better way than the English and Welsh Act, which talks about best interests, because best interests can become very muddy and very difficult to interpret, whereas will and preferences, from practical experience of having had discussions with various people, it's much easier to explain that the person in intensive care, what their previous will and preferences would have been, rather than trying to tease out and define what best interests would be. So I'm pleased you got will and preferences, and we can talk about that in more detail if you're interested, but I appreciate we've got limited time. Okay, so coming back to decision-making in intensive care. So few patients in intensive care die unexpectedly. And in fact, this is the Ethicus paper, which was published almost 20 years ago. Ethicus 2 is going to be published very soon. And I'm the UK's country lead for Ethicus 2. And it's an interesting paper, and I'd recommend it to you when it's published later on this year. So few patients die on ICU unexpectedly, and you won't be surprised to know that that's the same in Ethicist too. I'm not going to tell you how many die following some form of limitation of treatment, because my co-authors would string me up if I did. But in Ethicus 1, 70% of patients who die have some form of limitation of treatment. And then the Conflicus study, which is another critical care study, shows that there is a high degree of reported conflicts in intensive care. Now, these may be staff, so it may be the emergency medicine consultant who's referred a patient in who feels that we should be doing more, or it may be staff family, so it may be differences of opinion between the family members and staff members, or it may be family members. I was instructed in a case in the Court of Protection earlier this year, where the major disagreement was between the father and mother of a patient on intensive care, rather than between any other groups. So conflicts can occur. And end-of-life decision-making, conflicts can occur an awful lot. And so it's really important to have legal framework. So I'm harking back to your act. It's really important to have a structure so that you know how to resolve these conflicts. In the UK, this case that was a UK Supreme Court case in 2018, Lady Black had the only speech in that. And at paragraph 125, she says, if at the end of the medical process, it's apparent that the way forward is finely balanced, or there's a difference in medical opinion, or a lack of agreement about proposed court of action with those interested in the patient's welfare, the court application can and should be made. And I would absolutely agree with that. I think that's a really important thing to remember. But the other aspect of that is, if you can get agreement without going to court, then I think you should really try to do so. And this is where one of my interests comes in, so behavioral psychology. So some of you may have heard of Kahneman and Taversky. So Kahneman won the Nobel Prize for Economics. Unfortunately, Taversky, his collaborator, had died, and you need to be alive to win this prize. And they did some classic experiments, and this is one of them, the framing question. So how you ask people a question. So in this group, 600 people were asked to choose between 4 different programs. They were asked to choose between program A and B, and asked to choose between program C and D. And it's about a disease, a deadly disease. So this could be COVID. And they were asked to choose between 2 different options. So program A, 200 people will be saved out of the 600, versus program B, where there's a 1/3 probability that 600 people will be saved, and a 2/3 probability that no one will be saved. And so 72% of those participants chose A over B. Then the same participants were asked to choose between C and D. So in C, 400 people will die. In D, there's a 1/3 probability that 600 will be saved, and 2/3 probability that nobody would be saved. 78% chose D over C. Why is that important? Well, treatment options A and C are the same, and treatment options B and D are the same. So how you structure the question, how you answer the question, how you frame the issues influence the decision that comes out. So it's important that you get the conversation right. It's important that you actually make sure that people understand. And along with that, it's important to remember prospect theory. So prospect theory is also known as loss aversion. So we tend, as human beings, we tend to be hardwired. We are hardwired to avoid losses far more than trying to achieve a particular gain. So in terms of the loss of your loved one who's stuck on ICU, you will tend to move everything you possibly can to avoid their death. However, the patients who are going through this process, the loss may be the loss of independence, the loss of mobility, the fact that they are dependent on other people for their activities of everyday living. So their losses may be very different, and in which case there are certainly some of my patients who I've encountered over the years who perceive as death being a better outcome than being dependent on others for all of their activities of daily life for the rest of their life. I mean, the classic example, this falls away from cardiac arrest, but I remember a patient, a farmer, very active guy who had an injury such that he was paralyzed from the neck down. And this was completely unacceptable to him. And he absolutely refused to accept any more treatment on ICU and died. But this comes round to this quote from George Bernard Shaw: "The single biggest problem in communication is the illusion that it's taken place." And this is really important when we get groups of public talking to medics, medics talking to lawyers, lawyers talking to the public. You may think that you've actually communicated with the other participant in the conversation, but you haven't necessarily done so. So it's it can make things worse, and I've seen examples of that. And this is how I got into mediation. So mediation is the process where we try to end a disagreement by helping two sides talk. Now, there's good evidence, international evidence, that we're repeating in the UK at the moment, a study that has just finished recruiting within the Court of Protection. But there's international evidence from Canada which shows that mediation is very, very helpful. It's not appropriate to determine whether an adult has or has not got capacity, and it's not appropriate to determine whether abuse or any other crime has occurred. But beyond those exceptions, it can be extremely helpful indeed. And certainly during the recent COVID pandemic, I have mediated disputes in a number of occasions. I can't tell you about them because they're all completely confidential, but we have resolved very major differences between clinical teams and families. So pre-mediation meetings are key, and you need to have understanding of both law and medicine. Now, that may be a medic who's done a law degree as well, or it may be a lawyer who's got a particular interest in health law. The evidence for mediation from the Canadian study, it's the, if people are interested, it's the Centre for Elder Law, which is based in British Columbia, showed that mediation compared to litigation is cheaper, faster. 60 to 90% of cases will settle. 90% of participants found the experience useful whether or not the mediation settled or not, and it's a parallel track to litigation. So this is my 20 minutes, 10 seconds. This is my summary. So this is a gallop through my life as an intensivist. So return of spontaneous circulation is only the beginning. Neuro prognostication is really difficult. When you're stuck with somebody who has a significant brain injury due to the cardiac arrest, it's important to remember the will and preference of the individual before they had the cardiac arrest. Remember behavioral psychology, remember how to structure your conversations with people who perhaps don't inhabit your world. Disputes happen, you can't avoid it. Mediation can help. Litigation can be very destructive. Now, the key thing to remember about litigation is what happens the day after. So we heard from Judge Barr this morning. I'm sure he is a fantastic judge. But if he were to rule in a dispute over what was the will and preferences of a patient in hospital, what happens the day after he's made that decision? So he has moved on to another case. The lawyers in this audience will have moved on to another case. The family and the patient and the doctors and the rest of the clinical team will be back in the healthcare setting. And yes, there will be an answer about what to do, but the relationship between those people will have been really badly damaged. So yes, litigation, you can get an answer, but it's very, very destructive of relationships. So good quality CPR, everything that we've heard in the first part of the day, and early defibrillation is the way to avoid all of this so that we can get an outcome 8 on the Glasgow Glasgow outcome score. And we've returned our patient to a fit, healthy, normal, independent, active life. And I'm going to stop there.
Thank you so much, Dr. Danbury. That was fascinating. I've got a lot of positive messages back. Excellent presentation, Chris. Excellent webinar. Should be utilised as an educational aid for teams, clubs, sporting activities, etc., says Noreen. We are over time and I'm conscious of that. However, the question which has come in here is COVID-19. What sort of a knock-on effect did that have in the intensive care setting in terms of then treating people with cardiac issues and so on?
Okay, that's a resource allocation question. And how long have you got? I could spend the entire morning talking about this. It has an impact. It depends on the resources, the critical care resources available to the country concerned. Both the UK and also Ireland, I think, have got around somewhere between 6 and 7 critical care beds per 100,000 population. Those can only be filled with one person at a time. Once you're full, then you're full, and then something has to give. And you can expand the critical care resource, but only at by having a knock-on effect to other services. So generally what I'd say is people are treating the emergencies first, but elective work is what's suffering. So elective work is what's going to have the problem. So if you come in from following a cardiac arrest, you'll get an intensive care bed, no question at all. But it may be that the person who was scheduled to have cancer surgery that day doesn't get their operation that day. So that's the type of effect that will happen.
Very good. Just another message here from Scarlett O'Sullivan, whom you know, superb presentation, Dr. Danbury. Thank you from her as well. Loads flying in on my phone too. I'm really conscious that we're over time. What I would say is anyone at all here, but particularly the lawyers, if you've questions for Dr. Danbury, please email me. I can pass those on along with a copy of his very impressive CV. But because we're now at 12:15, I'm going to hand over, if that's all right, to Neil Johnson, who is, I'm going to hand over now to Neil Johnson, who is CEO of Croí, and he is going to just say a little bit about what they do, and most importantly, thank everybody who has donated today, and explaining the difference that your generous and kind donations will make to people's lives. So thank you, Neil.
Doireann, thank you very much. And it's been a very long session, and I certainly don't intend to delay people much longer. It's been a fantastic session. You have managed, Doireann, to put together clearly a panel of experts. We've got a very comprehensive overview of a very serious condition and how we are responding to it. And I want to thank you for taking the initiative to do this. And I want to thank all those who have contributed and those who have joined us, and particularly those who have made contributions to our work. I just want to very quickly take the opportunity for those who may not be aware of our organisation to just make reference to the fact that we are a heart and stroke charity based in Galway. We have a centre, and in that centre, which is a multidisciplinary-led health team, we are very much advocates for CPR training, and at any time, if people would like to visit our website, croí.ie, they can learn more about what's available in that regard. Can I just maybe also just say that as an organisation, the issue of sudden cardiac arrest it has always been something of concern to us. And over the years, we've been advocates for the widespread availability of public access to defibrillators. We've been providing CPR and defibrillation training. We have supported, initiated indeed, first responder schemes and community schemes. We've been available to provide advice and guidelines to community groups. We were very strong in advocating for the Good Samaritan law, which came into place in 2011. We found that there was some sense that people were slow to respond to emergencies due to the fear of litigation, and the Good Samaritan law clearly paves the way for people to respond with confidence. We identified the need for post-trauma debriefing, and it was very interesting listening to Cahill's story this morning, and disturbing, in fact, to discover that despite what he had gone through, he hadn't been offered, I think, or certainly didn't have access to cardiac rehabilitation. And he spoke very clearly about, I guess, the need for this post-trauma support, because it is a very traumatic experience. It's a traumatic experience to witness a cardiac arrest. It's a very traumatic experience to respond to a cardiac arrest. And it's obviously a very traumatic experience to be the person who has, who has arrested. And we have, for some time, been preparing to push forward many of the issues from an advocacy point of view around responding to sudden cardiac arrest in Ireland. And I'm not going to delay very long on this, but to pull a few threads around today's presentation, there's been a couple of very key messages from all the speakers. I think the first and foremost message is that sudden cardiac arrest is difficult to predict. It's obviously very traumatic. In the scheme of things, it is rare, certainly in the case of athletes and young athletes. But when it does occur, it is obviously hugely traumatic, and obviously very often there's loss of life. The very strong message I think we heard today, and I'd like to just reiterate, is that CPR and defibrillation are life-saving. And the key messages today around CPR and defibrillation are around, one, the availability of individuals in the bystander response who are trained in CPR. It is fantastic. I think the percentage was something in the high 80s reported bystander CPR in Ireland. I think actually that number reflects the good work that the ambulance service are doing, not just in their training of community first responders, but actually the way the call centers are guiding people through those critical response moments. And I've personally experienced that myself. I've seen it firsthand. Individuals who haven't done any formal CPR training, but are talked through by the ambulance controller in these traumatic circumstances. However, we do need more people to have the skill of CPR. And then we need people to be responsive with speed. So skill, speed, and then finally access to a defibrillator. These are three critical ingredients in terms of responding and giving somebody the best chance possible. So I would like to close with things that we need to do actually in Ireland, if I can. And one is, we do need more people trained in CPR. It's a fact that this is an easily learned skill. There was reference made to it earlier on around the possibility of training school children. As an organization, we're very strongly advocating for the idea that CPR training will become obligatory in second level education. The curriculum actually is designed to facilitate this. We now have wellness and they have a module in the name omits me right now, but there is a module in the second level system which would facilitate the training of CPR. It's not a huge burden for anyone to undertake, and we do know that if you are trained in CPR, you are more likely to respond. So it's a simple numbers game. The more people that know how to do CPR, the greater likelihood that they will do it and that they will produce a successful outcome. And there's data to support that. So one of the calls today is that people would join with us in moving to suggest that maybe we should make this obligatory. The second thing is that we do need, because there is an absence of national recommendations and guidelines in terms of CPR training, first responder initiatives, and equipment. And I mentioned very quickly a couple of issues here. First of all, a number of the speakers made reference to the fact that there are loads of defibrillators out in the community, and there are. And many community groups, organizations, and sports clubs have to be commended for taking the initiative to go out and get these devices. However, we have no strategy around this, and there are no clearly defined guidelines by which everyone is operating. And that presents problems. And the problems it presents are things around location of defibrillators, a standardized agreement as to where a defibrillator would be, whether it should be in a locked or unlocked environment, the question of maintenance, We have several examples of where defibs, and even Cathal himself made reference to it, defibs were called upon to discover either the battery charge had dissipated or it was dead, the battery was dead. And this obviously is a very, very worrying situation if you're trying to, in an emergency situation, trying to resuscitate. So assigning somebody, for example, to the management and maintenance of a defib on a site, this is something that we need to seriously consider in terms of recommended guidelines. And particularly in the context of today's discussion in sports clubs, many sports clubs have defibrillators. And again, they've put them there through their own hard work and fundraising. I don't think it would be a huge thing to introduce some sort of national recommendation that, in the same way as officers of sport clubs, for example, currently have to undergo Garda vetting, for example, from the point of view of child protection and safety, why can't we make it obligatory that they are at least trained in CPR? Not that they have any moral or legal obligation to respond in an emergency, because it can be quite traumatic. But again, the simple numbers game is, if the more people that are trained, the more likely it is that someone will respond. And given that time, and we're talking minutes here, is of the essence, how big of a deal would it be that every coach and elected officer of a sports club would undertake a CPR training program? There's the question of, also in terms of guidelines, the choice of equipment, the compatibility of the equipment with the ambulance service. These are some technical issues which I do believe need to be considered. There's also one issue which, from a government point of view, needs to be addressed, and that is the nonsensical situation that there is VAT on the purchase of defibrillators. So community groups go out into the community, they fundraise funds that already taxes have been paid on, and then with this hard-earned fundraising fund, they go to buy equipment, which they're then hit with a VAT bill on. It's crazy. And how difficult could it be to reduce the VAT on defibrillation? There's been reference today about knowing where defibrillators are. There's reference to websites and apps and so forth. We know from bitter experience, many years ago, we actually put a map on our website which listed the location of all the defibrillators that we ourselves, in the early days of public access defibrillation promotion, put out in the community. And there were almost 200 of these. And the intention was that by having a website locating these, that somebody could go and know where they were. And we had the unfortunate situation where somebody did go to our website, did in an emergency seek a device at that location to discover that it had been removed. And that put us in a very vulnerable position. So apps, websites, there's a lot of discussion around this, but actually there is the technology right now available to us on our mobile phones to locate, for example, the mobile phone itself. So the technology exists, and perhaps we should be making a strong case that going forward, defibrillators should come with a geolocator, or whatever the technical term is for that, which allows, most people now have access to a smartphone. So in the same way as that you can identify yourself in Google Maps, you can identify where a defibrillator is. You are still going to be confronted with the fact that that device may not be properly maintained. But again, in the context of national guidelines, if they were in place, there's a greater likelihood that we could avoid that. One other thing I would like to mention is in relation to the trauma associated with responding. And I don't wish this to be a deterrent to anyone to consider taking on the training. But we find that apart from the responder, you also have the bystander witnesses. And this, it can be a very traumatic experience, and particularly if the outcome is negative. We have struggled over the years to try and provide from our limited resources some sort of trauma debriefing service. I believe there's a need for some sort of centralized trauma debrief support initiative in circumstances of sudden cardiac arrest and in circumstances of bystander CPR. And finally, a related and perhaps in some respects not entirely relevant to this particular discussion, but in the context of COVID, it was drawn to our attention on a number of occasions that there are questions around whether or not there are whether there's appropriate access to defibrillators in care settings. And from the conversations and calls we've had, I think actually a very good exercise would be to have a review of the DNR, or do not resuscitate policies in care settings, because some of these policies seem to be inferred based on the fact that there isn't access, or there isn't an available defibrillator. And perhaps that's not the best thing, because there are lots of reasons why somebody in a care setting may be suitable and may wish to be resuscitated. I'm mentioning it in the context of defibrillation. So a lot of thoughts there, Doireann. I just have to say that we are really delighted that you, of your own volition and from your own experience of sudden cardiac arrest, honored us by reaching out to us and asking us to participate in this event. It has really been hugely informative. It has been recorded, so it will be available on the Croí website. You had a stellar lineup of speakers. You covered all the aspects. I hope that some of those people who joined us today have gone away with useful and helpful information. And if it does nothing else but drive home the message that CPR and defibrillation are life-saving skills, and that each of us as individuals should consider taking the few hours out to be trained and to know how to do this, because as we also know, the vast majority of these arrests occur in the home. And so someday some of us will find ourselves in this situation, and wouldn't it be fantastic to be able to respond and to be able to save the life of a loved one? Thank you. Thanks again to all the speakers, and thanks to everybody who participated today.
Thank you all.